Warm greetings from West Bengal Academy of Echocardiography to this first virtual conference of EZECHO, the annual conference of West Bengal Academy of Echo that we have been used to, uh, I mean, hold this under the banner of EZECHO every year. So, very good afternoon to all of you, esteemed delegates from all over the country. That has been one of the advantages of holding this virtual conference. So, I have been assigned this topic of evolving role of SGLT2 inhibitors in heart failure with reduced ejection fraction or HFrEF, as we term it. Uh, Not a directly echocardiography topic, but I think it has become a integral part of our heart failure treatment these days, and we need to know what kind of changes this group of molecules bring about in our patients, including the structural remodeling changes these agents can bring about, so that we can understand our patients better and treat them better. As you know, the story of SGLT2 inhibitors in heart patients as such is not very old. So it is barely the last decade over which this group of molecules have emerged. First, it was studied in patients with risk factors for cardiovascular disease, and then extended to patients with established cardiovascular disease. And finally, in the first mega trial, that is EMPEREG, we were pleasantly surprised by the reduction in heart failure hospitalization that was shown in this study. And that was hypothesis generating, so that we had other SGLT2 inhibitors joining the fray as well in this regard. And ultimately, we have embarked on dedicated trials of this group of molecules, namely dapagliflozin and empagliflozin, in patients with established symptomatic heart failure, so that it is now used in the treatment of heart failure per se. First trial I'm going to talk about is DAPA heart failure trial. This was a large trial of more than 4,700 patients, divided equally between the placebo group and the dapagliflozin group. NYHA class 2 to 4, LVEF less than 40%, and cutoff EGFR was less than 30. And here you can see that irrespective of the presence of diabetes, although this group of molecules were first seen as hypoglycemic molecules, but they have now emerged as specific cardiovascular drugs, especially useful in the reduction of heart failure, hospitalization, and cardiovascular mortality. So you can see the same kinds of benefit was seen in both diabetic and non-diabetic patients with regard to primary composite outcome in this trial. And even with regard to secondary outcome of CV death or heart failure hospitalization, again, equal benefits were seen in either group. The next big trial in this regard was the Emperor Reduced trial. And again, the study population, uh, took patients belonging to NYHA class 2 to 4. Again, a fairly large trial of more than 3,700 patients, divided into the empagliflozin 10 milligram once daily versus placebo group. And again, similar composite primary endpoints and secondary endpoints as in DAPA heart failure. But here, the EGFR slope was specifically studied. And here you can see that the first adjudicated CV death or hospitalization for heart failure was favorably reduced in the empagliflozin group, so that the relative risk reduction was a fair 25% reduction in favor of empagliflozin, and absolute risk reduction was reduced by 5.3%. And number needed to treat was a very, fascinating, only 19. Only 19 patients were needed to prevent one heart failure hospitalization or cardiovascular death. But it is pertinent to mention at this point that the main driving factor of this benefit was reduction in hospitalization for heart failure. The key secondary outcome, that is adjudicated total hospitalization for heart failure, that is the first or the recurrent hospitalization. Again, there was a remarkable 30% relative risk reduction in favor of empagliflozin. And again, like DAPA heart failure, irrespective of the presence of diabetes, the same benefit was seen in either group in the tune of say about 24 to 27%, irrespective of the presence of diabetes, and with regard to both time to first event of adjudicated heart failure hospitalization or CV death, and also for first and recurrent hospitalization for heart failure. And again, same benefits were seen irrespective of CKD status, so that irrespective of the presence or absence of chronic kidney disease, there was again a remarkable reduction in terms of these two key parameters, that is time to first event of adjudicated heart failure hospitalization or CV death, or first or recurrent heart failure hospitalization. And as I told you, another key point that was studied in this DAPA heart failure study was the EGFR slope. You can see in the EMPA group, it was minus 0.55 ml per minute, whereas in the placebo group, it was minus 2.28 ml per minute. So that in favor of empagliflozin, there was plus 1.73 EGFR slope difference. Thereby, the progression of kidney disease was slowed significantly in the empagliflozin group compared to the placebo group. And uh, in terms of serious adverse events, that was another major point of interest for us, because whether this remarkable reduction in heart failure hospitalization was secondary to the osmotic diuretic effect of empagliflozin, but it was not so, because there was no higher incidence of volume depletion, hypotension, or symptomatic hypotension in the empagliflozin group compared to the placebo group, and only there was a minor increase in genital tract infections in the empagliflozin group compared to placebo. But with regard to all other risk factors, there was no serious increase in adverse events. Now, this trial is very important in the context of this trial, the current conference, because this relates to the structural remodeling effect of empagliflozin that was studied in this EMPIRE heart failure trial. Now, there were two subgroups of the EMPIRE heart failure. One had 190 patients, and the other PCWP group had 70 patients. In the bigger arm, that is 170 patients, we studied the LV end systolic volume index, LV end diastolic volume index, the left atrial volume index, and left ventricular mass index. And you can see that there was a significant reduction in all these parameters in favor of empagliflozin use, thereby suggesting favorable reverse LV remodeling with empagliflozin compared to placebo. So whatever was seen with regard to the benefit in terms of CV mortality and heart failure hospitalization was just no fluke. There were definite structural remodeling effects that were shown with this group of molecules, especially empagliflozin in this trial, to justify that kind of outcomes. And with regard to PCWP also, empagliflozin use was shown to have a significantly greater reduction of PCWP compared to placebo, thereby again accounting for reduction in heart failure hospitalization. Now, this is a very important study because the other magic molecule we have discovered in the field of heart failure is ARNI. So everyone is keen to know whether one can combine ARNI and SGLT2 inhibitors in the same patient for a greater benefit or a synergistic effect or additive benefit. Yes, as this small trial, that is 132 patients, but nevertheless a very important trial from Singapore National Heart Center showed that we can definitely combine these two molecules. They are very well tolerated. There was only 7.8% discontinuation of either medication, acute kidney injury only in 6 patients, and hypotension in only 4 patients. Now, how does SGLT2 inhibitors compare to other standard of care in heart failure? As you can see that although there are other molecules with once daily dosing like SGLT2 inhibitors, but with regard to titration of dosage, this is the only molecule which does not require any titration of dosage in a very moribund patient who is suffering from heart failure. So that these people often have very low blood pressure, have all sorts of arrhythmias, they are very sick. So if you can give a molecule which does not require titration of dosage and yet can produce its remarkable benefit, that is indeed a very welcome story for us. Now, in the context of recent studies, one always wants to compare trials to trials. So how does DAPA heart failure compare to Emperor reduced? Is it a class effect? And that was studied by Fayed Janat and published in the Lancet. Here you can see with regard to this combined effect on heart failure hospitalization, CV death. I mean, both had similar kind of benefit. And so it was in terms of all-cause death and CV death, and so was it for with regard to kidney outcomes. Both the group of molecules had the same kinds of benefit and the same trend towards benefit. So it is not surprising that European Society of Cardiology update on SGLT inhibitors in heart failure has come up with this remarkable statement. Dapagliflozin or empagliflozin are recommended to reduce the combined risk of heart failure hospitalization and CV death in symptomatic patients with heart failure and reduced ejection fraction already receiving guideline-directed medical therapy, regardless of the presence of type 2 diabetes mellitus. So these are the fantastic four of heart failure with reduction, heart failure with reduced ejection fraction therapy now. So ARNI, MRA, beta blocker, and last but not the least, SGLT2 inhibitors. And of course, there are other fascinating molecules that are emerging, but today it is out of context, and in interest of time, I will not speak about them. And this is also another very remarkable statement that two doyens of heart failure, John McMurray and Milton Packer, have come up. The proposed new sequencing of therapy in heart failure. On the left-hand side, you can see the conventional sequencing, but what they have proposed is that the step 1 should comprise of beta blockers and SGLT2 inhibitors. Step 2 should comprise of addition of ARNI, and step 3 addition of MRA. So SGLT2 inhibitors have really been promoted to the first line therapy in patients of heart failure with reduced ejection fraction. So one should not forget, whenever one is embarking on the treatment of heart failure with reduced ejection fraction, of course, as I've already told you, these patients are very sick and each patient is different from the other. So we need a patient-centric, we need an individualized approach, but we should not deviate from the foundational therapies in patients with HFrEF. We have used beta blockers for a very long time now. We have used RAS blockers like ACE inhibitors and ARBs. And now we have also got used to ARNI, that is neprilysin inhibition, and also MRAs. And now, beyond type 2 diabetes, we should increasingly get used to use of these molecules, group of molecules, that is SGLT2 inhibitors. For the time being, the benefit is only restricted to dapagliflozin and empagliflozin in view of DAPA heart failure and Emperor reduced trials. But we should ensure that our patients are not deprived of the remarkable benefits of this group of molecules, because it will be indeed unfair to deprive our patients of the benefit of this group of very remarkable magic molecules, because they have produced a remarkable reduction in cardiovascular mortality and above all in heart failure hospitalization. So thank you very much for your patient hearing.